Okay. Good morning, everyone. My name is Leila. I'm one of the registrars in the department, and this morning we're going to have a discussion around quite a rare case, but or something we don't see that commonly, Zenker's diverticulum. But I thought I'd give an update on the management of this condition. So we'll start off with a case. It was a patient we saw not too long ago in our OPD, a 75-year-old female. She had background severe COPD and previously had an open cricopharyngeal myotomy in 2012 with the general surgeons. She remained symptom-free for about 6 years, but then represented with recurrence and was referred to us. So she had dysphagia, regurgitation, and quite significant loss of weight. They did do a G-scope before sending her across and confirmed that there was no tumor or suspicion of tumor in the pouch, and did a barium swallow at the same time, which showed a small residual diverticulum. The outcome, in summary, is that she was planned for an endoscopic approach. However, we could not proceed as she was quite a high anesthetic risk. I'll just show you some of her images. So this is her barium swallow on the left-hand side. So we can see she's got a small pouch, proximal esophagus, and no other significant esophageal lesions or stenosis or strictures as a result of the previous operation. And I put the X-ray there just to show you that she had severe COPD with hyperinflation, and this precluded us from proceeding. Okay, so just to jump into the topic, so Zenker's diverticulum was first described in about the 1700s already in a post-mortem exam done by someone called Ludlow. And after more than a century, Zenker himself published a full pathophysiological description and was then honored with the title of this condition. In definition, it's an abnormal acquired sac-like outpouching of the upper esophagus, and it occurs as a result of herniation of mucosa between fibers of the inferior constrictor muscles as well as cricopharyngeus muscle. And this occurs at Killian's triangle, which is a congenital dehiscence or muscular weakness which occurs in that area. It's also described as a false diverticulum as it only contains mucosa and submucosa. You get different kinds of pouches of the upper esophagus. There's the Killian-Jamieson, which goes between the oblique and transverse fibers of the cricopharyngeus muscle. There's the Lemire, which is between the cricopharyngeus and esophageal muscles. And then you also get lateral pharyngeal pouches. In terms of its pathogenesis, it's not yet fully understood, but there are some theories. So it's said to be a disorder of the upper esophageal sphincter opening. You get increased interluminal pressure in the oropharynx during the action of swallowing. And there's also inadequate relaxation of the cricopharyngeus muscle and subsequent incomplete opening of the upper esophageal sphincter. And then this causes protrusion of the mucosa and submucosa through an area of relative weakness as described earlier. So in terms of a history, when you're seeing a patient, generally these patients are in the older age groups, 50s to 70s. The median is actually closer to 70. Males are more affected than females. They can present with a wide range of symptoms, but the commonest is either a non-progressive or slowly progressive oropharyngeal dysphagia, and that occurs in almost 100% of patients. Regurgitation is also quite common, and that's exacerbated by positional changes, and is also more common, occurs more commonly at night as patients are supine. As signs of aspiration, so they can cough after eating and get frequent chest infections. Often these patients are missed because they just treated for this chest infection. They seem to be in the elderly population and at risk of frequent chest infections. And so then and as a result, the diagnosis is often delayed. They can get halitosis, and that's because of remnant food bolus sitting in the pouch, which is quite proximal. Also unexplained weight loss, and they can sometimes have a left-sided neck swelling. Examination findings are sometimes they can have such significant dysphagia that they're not eating as much and they get wasting. They get a soft tissue swelling on the left side of their neck. There's something called Boyce's sign. It occurs very rarely because it's only in very large diverticuli, but it's a swelling that gurgles on palpation, and the patient might even describe that to you. And on flexible endoscopy, you can see non-specific signs of laryngeal inflammation that occurs as a result of reflux, which is commonly associated with the Zenkers, or pooling of saliva in the piriform fossa. If you see blood in the regurgitated contents, this is a red flag and might suggest the development of a pouch SCC, which I'll go into a little bit later. When you're working these patients up, there's not that much that you need to do. So imaging is important, and a barium swallow with video fluoroscopy is the method of choice. And this characterizes the pouch for you. There are also descriptions of people using transcutaneous ultrasound, but barium swallow still remains the best imaging modality of choice. Manometry is done if there's symptoms of reflux, and it can tell you if there's abnormally increased pharyngeal intrabolus pressures. And then you also are obliged to do an endoscopic exam. So flexible and rigid assessments generally are done, and this can reveal fibrosis or pooling of food in the diverticulum. And if you're worried about malignancy, it's mandatory to do an endoscopic exam in order to rule this out. These are just some images. So it's AP and lateral X-rays showing different sized diverticuli. And I've just included a few more so we can have a view in your mind of what it looks like if you've never seen one before. There have been several grading systems described over the years. They're not that commonly used. This one that I've included is the Morton and Van Overbeek one. There's 3 grades, and it's according to the size of the diverticulum based on your contrast swallow. So grade 1 is less than 2 centimeters, 2 is 2 to 4 centimeters, and a grade 3 is anything more than 4 centimeters. In terms of a differential diagnosis, so things to consider is esophageal dysmotility disorders like achalasia. I've included a picture here. It looks very different to a Zenker's, but the symptoms can be the same. Gastroesophageal reflux is more of an association, but should form part of your differential. Inflammatory conditions like esophagitis of various causes, pre-malignant conditions like Comparative esophagus, and then also malignancy, which I will go into further detail on just now. So a squamous cell carcinoma arising in a Zenker's diverticulum was first described in the early 1900s. It's described in the still continues to be described in the literature as very rare, so an incidence of just 0.5 to 1.5%. There are some reported cases of SCC of the pouch which show normal morphology on endoscopy, so it wasn't picked up macroscopically, and the patient didn't have any suspicious clinical symptoms or signs. Contrast imaging and endoscopy could also miss a carcinoma, and the detection rate is said to be less than 10%. The only definitive modality of diagnosis is histopathological assessment of the complete resected pouch. And there is a recent report that showed that a PET CT could contribute to the diagnosis, but in our setting, it's not always that accessible. It takes quite long to interpret, and I think it possibly might be easier to make the diagnosis in other ways. So when should you suspect a malignancy? Well, the risk factors are increased age. It already this condition already happens in an older age population. And also if there's a large pouch size or long pouch duration, and the reason for this is that there's chronic irritation and inflammation because of the food or liquid bolus stasis in the pouch, and that causes cell changes. In terms of signs and symptoms, according to how frequently they occur, so sudden change in the character of dysphagia, so if there's any rapidly progressive dysphagia or increase in pain, and alarm symptoms, so ongoing and severe weight loss, any hemoptysis or hematemesis, or local worsening pain, and also pouch recurrence after previous treatment should raise some alarm bells. Moving on to the management, in general, the options are open surgery or transoral rigid or flexible endoscopy. There's been quite an interesting evolution in terms of surgeons of different specialties embracing technological advances in the surgical technique. However, overall, the aim is to eliminate the functional outflow obstruction caused by the pouch, and also to restore continuity at the pharyngoesophageal joint. The changes in these treatment modalities over the last few decades are actually a reflection of our better understanding of the underlying pathophysiology, and with a general trend to minimally invasive procedures, A concurrent decrease in mortality and morbidity has been noticed and has borne out in the literature as well. So the treatment option, we'll start off with the conservative. So this is only appropriate for asymptomatic or small diverticulitis, and that's less than 1 centimeter, and these would generally be picked up incidentally if you were doing a barium swallow endoscopy for another reason. So watching and waiting is always an option, but you must have excluded cancer if there were suspicious findings on history exam. And then things you can consider are referring the patient to a speech therapist, dietary modifications, putting them on some anti-reflux medication because there's close association between the two, Botox injections, cricopharyngeal muscle dilation. And then when you're sending your patient away, and are opting for a watch and wait approach, you should always counsel them about red flags. So unintentional weight loss, aspiration, pneumonia, and signs thereof. If they stop eating a certain type of food, that's very important because that represents a change in the character of their dysphagia, and then they must definitely come back for a reassessment, and much sooner than you might have planned. So moving on to the open procedures. So the first successful open resection was performed actually quite long ago in the 1800s. And then for many years thereafter, the Zenker's diverticulum was exclusively managed with various adaptations of this open surgical approach. But in the historical literature, the recurrence was always noted to be very high. And it was only that, and the reason for that is it was only in the 1930s, a man called Orban suggested partial resection of the cricopharyngeal muscle, which still remains a key component in our standard treatment. And then this then translated into much better or lower recurrence rates. So open procedures are indicated for larger or more extensive diverticulitis, or where endoscopic access or exposure is not possible. And it's performed by an external neck incision with always with a cricopharyngeal myotomy or diverticulotomy. And then you consider pouch intervention via one of the following 3 techniques. So it could be an inversion or invagination procedure, a diverticular pixie, or a diverticulectomy, which I've put an image of here. So myotomy alone is an option, and it's said to possibly prevent progression of dysphagia associated with small diverticulitis. A diverticular pixie or with a myotomy or suspension procedure, this is suitable for smaller diverticulitis, but less than 2 centimeters. An inversion or invagination procedure is where the diverticulum is inverted into the esophageal lumen and then oversewn. And this is for kind of moderately sized diverticulitis in the range of 1 to 4 centimeters. And then a diverticulectomy with a myotomy is best for larger diverticulitis, anything more than 3 to 4 centimeters. And it must just be kept in mind that this carries the same risk associated with an esophageal repair. So the complication rate is said to be much higher. The current literature shows quite heterogeneous results in terms of outcomes for these different procedures. There was a study, a Mayo Clinic series of almost 1,000 patients who underwent a diverticulectomy, and it actually shows the morbidity and mortality are quite low. Recurrence rates are also low, less than 5%, and they've all got had excellent or good to excellent relief of their dysphagia according to the E10 score, which is a dysphagia score of about 93%. There was another very comprehensive review of the literature for Zenker's diverticulum of almost 3,000 patients from a large number of studies, which showed that the overall morbidity for open procedures was only about 11%. And I'll go through those complications a bit later. And then it said that the open surgery resolves symptoms in about 90 to 95% of patients, which is quite good. Recurrence rates are equal to or slightly better than endoscopic options, but then this comes at the cost of considerably higher complication rates. So just a bit more on the open procedures. So some authors actually advocate for extension of your myotomy for about 2 to 3 centimeters into the muscularis propria, and this is a potential way of reducing the risk of recurrence. There are concerns for increased risk of mediastinal exposure or perforation or even vascular injury, but this is more so with huge kind of floating or plunging diverticuli. And then a diverticulectomy or diverticulopexy without myotomy is now no longer recommended at all. It's associated with very high recurrence, and it's the reason is that you're actually failing to address the underlying functional abnormality. So there's kind of no point doing these procedures without doing myotomy. Moving on to the endoscopic treatment option. So described in about sort of mid-century 1960s, and this technique entailed dividing the common wall via diathermy. A man called Dolman did this first. This was an option, became an option in kind of older multi-morbid patients who were said to be unfit for open surgical procedures. You can use a rigid or flexible endoscope. It involves only a diverticulotomy, so you're only dividing the septum between the esophageal lumen and the diverticulum and the cracopharyngeus muscle, and you want to essentially create a single channel. It's got about a 92 to 98% success rate at addressing dysphagia, which is really good. They have said to be a 3% conversion rate to an open procedure for various reasons. In one study, there was a 0% mortality, less than 3% morbidity or complication rates, and recurrence rates were about 3 to 10%, depending on the modality. So it's slightly lower than that open procedures. And I just included these images to show how the diverticular scope is inserted. So it's a two-pronged scope. One prong goes into the pouch, one into the esophageal lumen. This is how your endoscopic view pre-treatment and post-treatment. This is what you expect to kind of see. So the advantages of the endoscopic approach is that it's a shorter operative time. These patients have a reduced hospital stay, a quicker resumption of the oral intake, and lower complication rates. But the good thing is that it's as effective as open surgery in palliating dysphagia. The techniques, so there's several techniques. There's a staple-assisted CO2 laser myotomy, and then there's other less common options in our field, so the harmonic scalpel, as well as flexible endoscopic diverticulotomies. These are mostly done by the general surgeons. In terms of the stapler, so there's a possible increased recurrence rate if this technique is used. It's 10% in the stapler versus 0% in the laser, according to one study done at Yale in 2012. Preservation of the inferior cracopharyngeal fibers theoretically results in increased recurrence rate, and this technique is not for diverticuli that are less than 3 centimeters. And that's because of kind of technical things related to the actual scope. Introduction of the scope or stapler is also limited in some patients for various reasons. Laser, so there's fewer recurrences and faster improvement in symptoms, according to studies, and this is compared to the stapler technique. It does allow for a more aggressive approach where all the cracopharyngeal muscle fibers can be divided. There's a theoretical risk of fascial violation of fistula and subsequent mediastinitis, which is increased compared to the stapler technique, but there is similar symptom improvement. And then there was a study published in 2006 in the Ringerscope, which showed that the laser group had a higher length of stay and more complications compared to the stapler group. These images at the bottom just show your endoscopic view initially with the bar. That's a bougie inserted into the esophagus to show you the direction of the esophagus and where the esophageal lumen is, because I think it can get quite confusing sometimes. And that's to show how the bar has been released or was burned with the CO2 laser. And this is barium swallow pre and post. So the question of open versus endoscopic, there's so much literature on this, but to date, none of the available studies actually demonstrate a substantial superiority of one technique over the other. There was a study done in 2014 that said that although the open approach offers effective symptom resolution in about 95% of patients, the complication rate does approach about 10%. A rigid endoscopic approach offers a comparable symptom relief with about a 7 to 8% risk of adverse events. The limitations of using a rigid scope is things like if the patient has upper teeth protrusion, if there's inadequate jaw opening, limited neck mobility, and also if they've got severe C-spine osteoarthritis with osteophytes. With a general trend towards a more minimalistic approach overall in surgery, a flexible endoscopy is also an emerging attractive alternative. It can overcome some of the technical limitations of open surgery because the scope is flexible and able to get into areas that possibly a rigid scope can't. And this is compared to open and rigid scope techniques. In terms of patient-reported outcomes, so there was a recent study in 2019 where they did a systematic review and meta-analysis to look at what do patients say after they've had different interventions. And the aim was to compare if the open diverticulectomy was better than the endoscopic laser or stapler diverticulectomies according to the E10 dysphagia score. And they had a large number of patients in publications. And interestingly, it did not prove that the open approach has any superior outcomes for patients compared to the laser or stapler techniques. And the conclusion was that any method of surgical intervention actually yields a large effect or a good effect with improvement in dysphagia and regurgitation. So going on to the complications for open procedures, there was the study that I quoted earlier where they looked at a large number of patients from many studies. The overall morbidity, like I said earlier, was about 11%. Specific complications that they noted was a recurrent laryngeal nerve injury in about 3% of patients, a leak or perforation occurred in 3% of patients, cervical infection in just 2%, and then fistula formation and abscess or hematoma was in less than 3%. Endoscopic, so complications specifically related to the endoscope, so dental or oral soft tissue injuries, mucosal type tears and things like that. Pouch perforation did occur in some patients and also bleeding, but the numbers were very low. And then this image just shows an abscess post an endoscopic procedure that was done. Just to mention crepitus or subcutaneous emphysema. So this actually occurred in about 10% in a small case series that was done, and should be looked for after any intervention. It typically does resolve on its own in about 2 to 5 days, and if it's minimal, you can just observe it and continue them on their diet. However, if there's progression or if it's extensive, then you're obliged to do a contrast swallow study and also feed them via tube for 7 to 10 days because of concerns for a leak. So going on to the post-op management. So the guidelines vary according to the approach you use, and it's also quite institution specific, but generally, if you've done an open repair, these patients are kept null for us for about 3 days and are on nasogastric tube feeds, and you can start clear fluids on that 3rd day and then progress with the graded diet after that. If they've had an endoscopic intervention, you should observe them at least overnight for medius stenitis because pouch perforation is a concern. They can start on a clear diet same day or next day, and then you can actually discharge them if they're tolerating a clear liquid diet to go home and then progress their diet if they're reliable to follow up. And obviously, if you're concerned, rather keep them and make sure that they're well established on a full diet. And then you only do a post-op contrast swallow study if you suspect a complication or recurrence. Moving on to recurrence. So it's in the range of about 8 to 15% according to some studies, and it occurs about 0 to 60 months after treatment. So it can occur quite early or quite late. And the general reason is that the stenosis of the cut party will near the apex. And methods to reduce recurrence is manage them with a PPI or for reflux post-operatively, and also use a technique that gives you the smallest residual pouch. And then if they present with a recurrence, the endoscopic staple diverticulostomy is the treatment of choice. Okay, so in conclusion, the presence of a Zenker is in itself not an indication for surgery. It's very important to exclude a malignancy if clinically suspicious, as this occurs in an older population group already at risk of malignancy. There are several management options, as we've discussed, and patient-reported outcomes are comparable. The routine use of myotomy is now mandatory. The management and therapeutic approach to a Zenker is actually far from being standardized, and the optimal treatment option remains unsettled. And the best approach is said to be the one that affords the greatest relief of symptoms and provides lasting results and has the lowest risk for that particular patient. Thank you. Thank you for your time. And these are my results.
I think there's a really good summary of there's a few comments. Firstly, I mean, the language with the endoscopic approach, always caution the patient that the either on the patient can't get you instrumentation in. So those ones I would then wake up and discuss the open patient. And as you said, for the very small pouches, you can't use a stapler because there's always that the last centimeter or so that the stapler can't cut and can't staple those ones that can't use the prefaces. It's important to tell your anesthetist not to bag the patient when you're making the cut. Because there's always going to be small communication. And so if they bag the patient, you should go areas. And certainly when that happens, I'm always very concerned. The next thing is that I think some of the patients that have subsequent ongoing dysphagia, it might not be that it's an incomplete stomachotomy, but it could just be that remember that the wall of the pouch has got no muscle in it. And so you've got this section of of the upper epiphyseal tract, which is just a bag of mucosa. And so I suspect some of it is more an ability issue rather than pouch. I don't routinely do the subsequent variant swallow, but you very good patients that are sympathetic. Because what you see doesn't matter, it's the during function is. And then also remember that if you do perforate the pouch, it's actually a big problem because there's no muscle in it. So you just got mucosa and then fat beyond it. So one really has to be very, very cautious about perforation. Last thing is to get your scope into the esophageal lumen can be quite challenging. And so there are certain tricks around that. You can't get it in the right with bailout. Because the complication of perforating and puncturing. So those things are yeah. So they'd be nervous.
Yeah, very nervous.
Yeah, because the instrumentation is very powerful.
I need a few that I just like quick comments or like you said, but the recurrence, you must just be careful how you define it, because if you define it radiologically and you've done a transoral approach, inevitably you have always have a bit of the party wall which remains, and it looks like if you want to call it a pseudo Zenker's diverticulum or true diverticulum, it's not something you're going to address. So again, just routinely doing variant swallows is on that regard. My understanding was that laser and stapler outcomes in terms of recurrence, the systematic reviews had shown that they were comparable. But there's obviously selection bias in that inevitably if you have both tools, like Prof said, you're going to use the laser probably for smaller Zenkers where you can't get the stapler around, so you're not really comparing Zenkers. And then I just want to ask you, Prof, in terms of the incidence of malignancy in the pouch, if I understood you correctly, you said there have been incidences of pouch malignancies in morphologically or macroscopically normal looking pouches. So is that normal pouches on examination? Because we always prior to dividing the party wall, look with an endoscope and examine the mucosa of the pouch. We won't biopsy it. I'm correct, Prof, unless there's mucosal abnormality or an abnormal stricture. Does that imply that they were biopsying all the mucosa, or is that just Zenkers which look radiologically fine procedure? No.
So that was a specific case where they scoped the pouch and they didn't see anything, so they didn't biopsy, and then when they did that, they actually didn't open diverticulum, so they dissected the pouch, and then when they looked at the specimen, they saw something cystic, and they sent it away. That was one case.
But that must be very rare.
Yeah.
I think it's important point that the inspector starts at the time of surgery.
Yeah.
But I wouldn't blame you. But typically, these are often older patients, and I never talk a patient into an operation, and they must want to really have it. Because some patients, they modify their diet stuff. They find it. So it's another, if I actually it's good for the patients, actually. I think they have to log. Any other questions from the audience? Comments?
I don't see any questions in the chat.
Yeah. Sorry. Very fast. Unfortunately, I didn't put very much. So, but as I said, I think the difficulty is that they might take a long time to deal. So it is probably a situation where I probably find the verdict and find closer to the piece. They can be difficult to work with the right hand. And behind that are eating procedures. There are tricks sometimes worthwhile just packing the pouch endoscopically before you go find it, because it's all collapse when you go in. And then the other risk is you second too much of the pouch mucosa, so you get a stenosis. The one trick there is to pass a dilator or peel tube down the esophagus before you do the open procedure. And it also means you can palpate where the esophagus is, so there's a few tricks to try and avoid taking people to the
Yes, and a very good presentation. How often are you likely to see a neck?
very hardly. Very good. Thank you very much. Very nice.
Thank you. And thank you, everyone. We'll meet again next week, Wednesday.
Yeah.
Thank you.
One